all the respected doctors present here. I, Dr. Snehal, welcome you all for yet another interesting session in the CME India series, where we will be touching upon a very important topic, that is endoperiatric technique on board for obesity. Without much ado, I would now like to introduce to you our extremely talented moderator for the evening. We have with us Dr. N.K Singh, sir. Sir is an MD, FICP, FACP, RSSDI, Diabetes India, Diabetologist physician from Dhanbad. Sir is the Director for Diabetes and Heart Research Center in Dhanbad. He is the Chairman for RSSDI Jharkhand, Executive Member, National RSSDI, Ex-Government Body Member for National API, Ex-Chairman API Jharkhand and CCDSI BJ. Edited Millennium Book of Medicine. He is the Associate Editor for the Postgraduate Medicine 2021. He has edited a monograph on COVID by ICP and API 2023. He has more than 40 publications to his credit in reputed international and national journals. He is the admin and founder for CME India, editor for www.cmeindia.in, and has completed his fellowship from WHO. A warm welcome to you, sir. Thank you for giving us your time. It's an honor to have you on board. With this, I hand over to you to introduce our panelists for the evening. Over to you, Singh, sir.
Yeah, thank you, Dr. Snehal. Today, it is a great time that we are going to learn something unique from a very learned speaker and from the AIG Hyderabad. Dr. Rakesh Kalapala is known to most of us, but those who do not know, he is doing a marvelous job in this field of medicine. So I think today we have got the two eminent persons as a panelist. Dr. Rakesh Kalapala will be introduced by Dr. Ripun. So let them, I will introduce Dr. Ripun, who is the chair RSSDI Assam chapter, RSSDI district coordinator as current. He was the former joint director of the Health Services Government of Assam and past president Association of Physicians of India, Sivsagar, till 2022. Expert committee members in chapter write-up on diabetes and heart, co-investigator in many pan-Indian studies, faculty in different forums. So welcome, Dr. Ripun. And next, please show the Dr. Vinay K Dhandhania. He is the secretary. Please change the slide. Yeah, he is a consultant in diabetes at I think NMMSS and Orchid Medical Center, Ranchi, secretary RSSDI Jharkhand. And he has been associated with many eminent studies and even the very recent studies, and the life member of the RSSDI, DFSI, UDF, Red Cross, IMA and others, member Endocrine Society and ACE USA, and principal investigator for ICMR in DAB study, which I was talking about, and 14 publications in international and national journals. So welcome, Dr. Vinay Kumar Dhandhania. Now I will request Dr. Ripun to take over and to start the proceedings. Dr. Ripun.
Thank you, Dr. N.K. I would rather call you the father of CME India.
Oh, thank you. Thank you.
For giving us the opportunity to be a panelist in this important session. We all know the obesity is now a menace to the modern human society, with alarming rise in the incidence and never showing the signs of slowing down. And what is more important for all of us, we do not have evidence-based, durable, and efficacious treatment modalities for obesity, excepting, of course, the bariatric surgery, which a recent report published in Lancet May 2021. It has shown that it can reduce 50% of all-cause mortality in obesity with type 2 diabetes, and 30% of all-cause mortality in obese people without diabetes. But we all know that it has got a limitation. The basic criteria for going for bariatric surgery is you need to have a BMI in the patient to be more than 35 or so. How that can be applicable in India is a very important question, of course. But right now, we do have so many new modalities of treatment of obesity. We fortunate to have Dr. Rakesh Kalapala here, the Senior Consultant Gastroenterologist and Director, Center for Obesity and Metabolic Therapy in AIG Hospital, Hyderabad. You will be talking on, you can see a lot of credentials to it, very young, energetic, and he has done a marvelous job. He has been doing a marvelous job in the field of endoscopic bariatric therapy or treatment modalities, whatever you say. We all know the barrows means wet and IAT means treatment. So this is a new modality of treatment, and many of us, including me, do not know much about the different types of endoscopic procedure to cut down the obesity. And it's our fortunate to learn from Dr. Rakesh Kalapala. He has got so many fellowships of FSGEJ, so-and-so in gastroenterologist and clinical research, and primary investigator for various trials. And with these few words, we know we can learn from you. Over to you, Dr. Rakesh, and all the best. Thank you.
Thank you very much. So at the outset, I thank Professor N.K Singh, Dr. Ripun, and other people, and also the USV Pharma for extending an invitation and giving me an opportunity to talk in this August forum. So before I go into the talk in specific, so I think this is something which is not very much exposed. In fact, I would say that many of the gastroenterologists and endoscopists across the world are not having a depth of the subject of this, because it's an evolving subject. In the last 5 years, precisely, it's taken a big leap. So coming to the physicians and diabetologists or the endocrinologists or the people who deal with the metabolic disorders, this is something which everybody has to have exposure, knowledge, and then understand to which patient is ideally suitable for these kind of therapies. So I don't waste time. And Dr. Singh, what's my time, talk time? How much accordingly I'll go forward?
No, you take your time, sir. We have got 1 hour, so you can take your time, then we will discuss.
Yeah, because I don't go into the depth of it, but the superficial, because I want to deal in my talk in 3 phases. First phase is what exactly is necessity for weight loss. Second phase is about the therapies which will give weight loss only for obesity, and then obesity with diabetes, which is more important in our scenario. So as you see, if you start my talk, the frequent behavior of an obese, I don't say obese patient, obese person, because obesity is not a disease, because many people will feel offended when you call an obese person as a patient. So any obese frequent behavior is you try to do something with the weight reduction in terms of diet modifications, lifestyle change, exercise. You lose around 10 kgs, or you might not lose. Then you go to a bariatric surgeon. He or she will say, go for a surgery. It's not 95%, 99% refuse. Then you go for magic solutions, keto diet, Mediterranean diet, Atkins diet, so on and so forth. You lose, you again regain weight. There will be failures, loss of confidence, regain of weight, again change in diet. It's a vicious circle. And with our busy life, what we are all of us, we can be one of those Bollywood khans who will spend hours together in the gym and have some specific diet. So endoscopy has taken in the recent past a logical progression. Like we all know about the orthopedic people, when they have had these earlier exercise and medications, then there was a joint replacement, but now they have a mid-level through which they do some minimally invasive procedures called arthroscopy. Again, in cardiology, we know there's nothing to, it's beyond any discussion that angioplasty has given a kind of, challenge to the cardiothoracic surgeons, because most of them are done by angioplasty. In the same way, for the bariatric surgeon community, bariatric endoscopy, I don't say is giving a competition, but it's going to be a complementary therapy in the next 1 to 2 decades. We all know what happens in this endobariatric mechanisms is, I'll briefly just go through, I don't want to bore you with the theoretical part. So there will be increased insulin sensitivity, which I'll tell you how it happens. Then delayed gastric emptying, that is, it will induce artificial gastroparesis, accelerate intestinal transit time, then enhance the release of this GLP-1 analogs, then improve the bile flow, and thereby improve the metabolic profile. And also, trust me, it will also give a restoration of the gut microbiome. I'll tell you how it happens. If you see the bariatric endoscopy in 2022 or 2023, these are the things what we do and what are there in the market. The gastric space occupying devices, that is the balloons you must have heard of. Then there is something called as endoscopic suturing or endoscopic sleeve gastroplasty, which we do with some instruments. Then you have this duodenojejunal, the things which act at the duodenal level, which are for diabesity, not only obesity, diabetes and obesity. And of course, we also play a role when the surgeons do some bariatric surgery and they come with complications. So primarily what you have to understand is there are two things which we do in bariatric endoscopy. One at the stomach level, second at the duodenal level, that is small bowel level. What we do at the stomach is basically which will induce weight loss and indirectly will have metabolic effects. But what we do at the small bowel level is metabolic effects primarily, and that will give some indirect weight loss. I'll tell you how it happens. So one thing what as a physician or a diabetologist who's dealing with day in, day out with metabolic disorders or obesity is something which you have to put into a patient's or into your patient's mind is rule of 10. You should not pester on them. You have to lose 20 kgs, 30 kgs and all. 10% weight loss is good enough, rule of 10. I'll tell you why. If you lose 10% of your body weight or the baseline, then you will have a positive effect from head to toe in terms of hypertension, diabetes, insulin sensitivity, hyperlipidemia, then certain cancers which are more predisposed in obese patients. Then, of course, osteoarthritis and other arthritis conditions, obstructive sleep apnea, improvement in the energy levels, improvement in the self-esteem, and also improvement in sexual dysfunction. So these are all the things which happen when you have a 10% weight loss. That's why we as gastroenterologists or you as diabetologists or physicians or endocrinologists should emphasize on any obese person to have this rule of 10. And the interventions what we do in the stomach are basically divided into two categories. One is these balloons. Second is the endoscopic sleeve gastroplasty. Balloons, we usually have this gastric, the air-filled and liquid-filled. Most of the balloons in the market are liquid-filled. And we usually put it for, they have a 6-month balloon and a 12-month balloon. By and large, we have now the 12 months balloon. And most of these balloons will have around 10 to 12% weight loss. That is what we have to understand. It's a daycare procedure, easily doable. All you have to do is patient should be called on empty stomach, inflate the balloon, put it inside, 10-minute job. And then after that, you give a specific diet chart, which will be followed. And then call them back after 3 months, 6 months, 9 months, and then assess the body weight. By and large, the data on these intragastric balloons, as you see, these are multiple balloons in the market, but we have 3 or 4 balloons in the Indian market. And as you see, at 6 months and 12 months, the average weight loss is around 10 to 12% if you see the total body weight loss, and excess body weight loss is around 19 to 20%. And there is some advancement in these balloons, which is called as, the ingested balloons without any endoscopy, where a person comes into our office, you just have to put in the pill like a swallow capsule. And once it goes inside, you inflate the balloon with this tag, which is externally outside, and the balloon inflates. Then we will pump in some normal saline, and then it will take a shape. After 6 months, we will take out the balloon. So another interesting is you don't need an endoscopy at all to deploy or remove the balloon. So there is something called as swallowable balloon. So this is, I think probably you must have heard in the market, where we get this balloon inside, make the patient swallow. And then once a balloon gets into, then we inflate the balloon with this normal saline methylene blue combination. It swells up. After 4 months, this balloon disintegrates itself, and then it will be excreted out into the fecal matter through the intestine. So that is again a 4-month affair. We'll lose around 7 to 8%. But what I want to emphasize at this level is the conventional balloons will have a more better weight loss than the swallowable balloon. But of course, it is not yet FDA approved. As you see on the screen, the animation, the balloon dissolves at 4 months and then it gets excreted in the feces. You don't have to either put in a scope before or after the procedure also. So there's another balloon which we commonly use in India, that is a swallowable balloon. See, what happens is earlier they used to have a non-adjustable balloon where the person balloon after 2 to 3 days, there is a lot of discomfort. We used to take it out. But this adjustable balloon, you can upsize or downsize the balloon, and which studies have shown that this balloon has got more better weight loss compared to the non-adjustable balloon. As you see on the screen, this is in publication in Lancet, where the adjustable balloon, see what happens in is all these procedures, after they lose a certain weight, they get into a threshold. So that's where you need to increase the size of the balloon. So, and as it is shown on this, at 5 months, there is an upsize of this adjustable balloon where it led to even more weight loss of around 14 to 16 kgs. So that's what I want to emphasize. So we just concluded a study in this patients of obesity with NAFLD or NASH, and then we have put this balloon and then they did a US guided liver biopsy to see the changes in the liver steatosis and liver fibrosis scores pre and post balloon adjustment. We just came up with the results also, soon to be published. The second part is, without this balloon, there is something which we can do endoscopically, like how the surgeons do laparoscopically, which is called laparoscopic sleeve gastroplasty. So this is endoscopic sleeve gastroplasty. There are different devices. I don't want to go into that. What we use commonly is this device called Apollo Overstitch, which is widely available in India. This again is a daycare procedure. As you see on the screen, we grab the mucosa of the stomach, then put this suture, which is a transmural suture, and this suture will be put like a U pattern on the stomach, and then we make the stomach like a tubular organ. It's called as accordion stomach. So that leads to decrease in the accommodation of stomach and thereby decrease in the intake. Suppose in simple language, what I tell my patients is, if you're eating 2 chapati at one shot, you will feel fullness with half a chapati. So that's what happens with these luminal restrictive procedures. And there is robust data on that. This is FDA approved, and this is the 2-year follow-up on this ESG, where they have 15 to 18% weight loss consistent up to 2 years. Then there is a 5-year follow-up from a New York group, which also showed the same weight loss up to 15%. And we from our group have published a paper on this, where we did endoscopic sleeve gastroplasty in patients with obesity and NAFLD. And post 6 months, we found the non-invasive fibrosis markers having significant improvement in the fatty liver. So this is the data which we have published. This another, of course, I don't want to get into this, another device which is available in US but not in India. And this is also has shown equivalent amount of weight loss. This is again another device called Endomina, available in Europe. We also have it. This also has got a similar mechanism, but a different company. And with this also, we just started a multi-center trial where we are doing this ESG in NAFLD and obese patients, and then doing a liver biopsy to see pre and post reversal of fibrosis. So the data cumulative on endoscopic sleeve gastroplasty, different published meta-analysis trials, all have shown around 12 to 15% weight loss in 3 to 6 months. If you compare endoscopic sleeve gastroplasty with laparoscopic sleeve gastrectomy, both are equally efficacious. And in fact, the morbidity is very less. If you see any patient who has come with a post-bariatric surgery, the sleeve gastrectomy, there is a terrible incidence of GERD post-surgery, where 30 to 40% will have a miserable life because the GE junction is cut off. Whereas in ESG, you don't have that problem because we are not fiddling with the GE junction or the fundus. That's one advantage. And of course, I'm not saying ESG is equivalent to LSG, but people with BMI between 30 to 40, that is class 1, class 2 obesity, I didn't show here, but there's a recent published MERIT trial published in Lancet, which is the first randomized controlled trial they have done from the Mayo group, where they have taken ESG on one arm and lifestyle on another arm. And then they compared with a crossover, where they have found improvement in quality of life index, improvement in the metabolic parameters like diabetes, hypertension, dyslipidemia, improvement in the weight loss is much statistically better than in the lifestyle modification. That is what I want to emphasize. The second part of my talk is something which you all must be really looking forward, and in fact, me or every one of us in Indian scenario, is anything related to all these burning pandemics of diabetes, obesity, and fatty liver. We as gastroenterologists are very much worried about fatty liver because trust me, you all also know, you're all a learned audience. Fatty liver with diabetes and obesity, I am telling you, trust me, the incidence of hepatocellular carcinoma is superseding the hepatitis B and hepatitis C. And people who have fatty liver, if you have 25 to 30% of people with NAFLD and NASH are having an incidence of HCC in a long run, which is something very alarming, very striking, very scary. And that's the reason why when you have all three in this combination, the USP now is you don't have to say, I will treat your diabetes and I'll treat your obesity. If you say, I will treat your fatty liver, that is something which is very scary because the long-term side effects or consequences of this is very bad. So one thing I want to put forward at the basics is the physiology is duodenum is now considered epicenter for metabolic control. Earlier, we used to think that pancreas is the main control center for metabolism. But as you see here, the glucose metabolism, of course, happens in the pancreas. But now the new concept is the metabolic control center is in the first part of duodenum. As you see in the animation, you see on the screen, this is a nutritious meal, which if you eat, the incretins and anti-incretins, which are placed on the brush border of the small intestine, the duodenal first and second parts. When you have a balanced diet, then there will be a balance between the incretins and anti-incretins, which leads to balance of insulin sensitivity and euglycemia will be maintained. But it's not common all the times. Whenever you go to the conferences, when N.K Singh organized some beautiful conferences in Kolkata, which have been last year once, then after any of this sumptuous meal, there will be an imbalance between the incretins and anti-incretins, which leads to hyperglycemia, hyperlipidemia, insulin sensitivity resistance, and NASH. So this is where the key mechanism of disbalance between incretins and anti-incretins lead to this insulin resistance and other things. So that's where we as endoscopists, of course, surgeons started doing this much earlier, is something interventions on the small bowel. We all know about the Roux-en-Y gastric bypass, which many of your patients must have done. They have a fantastic improvement by becoming insulin independent also, a few of them, or if not, then they'll have decrease in the dosage of insulin and then getting out of the oral hypoglycemic drugs. So this is proven beyond doubt in literature that Roux-en-Y bypass or the one anastomosis bypass, what surgeons do in a diabetes and obese patient, they have fantastic improvement. But again, as I told you, only 1% of the patient population will come onto the table for a surgeon if you want to convince them for a bariatric surgery. So at this level, the endoscopy community started working on why can't we do something at the duodenal level where we can stop this absorption of nutrients which the food is by passing through, whereby there will be improvement in the production of this GLP-1 and GIP-1, the analogs from the enterochromaffin cells. So there the concept of duodenojejunal bypass liner concept came. And there is one device in the market called the endo barrier, which people must have heard, which has been widely used a couple of years before. And there was a marked improvement in the HbA1c levels by 1.23, 1.5% with a total body weight loss of around 10 to 12%, 14%. But there was some issue in the with this device where they had some liver abscess because these barbs in this device penetrated into the serosa and then caused liver abscess. So with this in the mind, we at AIG started working on a device called EndoSleeve with a company from Metamodics called Metamodics from Minneapolis in US, where we modified this and started working on a device which looks like this. As you see on the screen, this is the pyloric. I'll show you in an animation or the video exactly how it looks. So let me get into the video in specific. So this is something which is very interesting, close to my heart. And we are working on this. Probably we'll be succeeding in the next 6 months. So as you see on the animation, so this is a pyloroduodenal stent with a sheath which covers the duodenal mucosa. This sheath is made of polyteflofluoroethylene. So as the person eats, the food will go through this and then it will bypass the duodenum and gets into the jejunum. So the absorption of nutrients won't happen at the duodenal mucosal level. So this is the human case which you can appreciate. And because the absorption doesn't happen, the food is not absorbed in the duodenal mucosa and it directly gets into the jejunum. So you see here that the stent is deployed and that white part is the sheath which covers the duodenal mucosa. Removal this hardly takes 20 minutes. Removal is pretty much easy. We again have to just do the same endoscopic procedure, a daycare procedure. You just deploy the device and then send the patient back. Again, the same thing where you just pull this device with a small lasso and then it hardly takes 5-10 minutes. The main aim of our group working on this is this should be done by an average endoscopist and with a very bare minimal cost in any simple endoscopy center. So that's how the concept started. And we did the first in human trials in pre-COVID. And of course, COVID has taken a little backseat. And what we have found very interesting in the first animal studies is there is improvement in the HbA1c. Sorry, first human studies is improvement in the HbA1c by 1.8% in 3 to 6 months and improvement in the total body weight loss by 12%. But again, it doesn't look as, it's not as rosy as it looks. So there were some issues of migration of this into the duodenum. So we went back and then assessed the pyloric sphincter physiology. And now we have gone back to the bench side, did some animal experiments in US. And then we are trying to fix this so that this device won't penetrate into the duodenum. And we have come up with some solution. We, in fact, last Dr. Singh and everybody were there. We did a workshop in that recent conference where we have shown to the first time to the world this device, how it is deployed. The second part of this duodenal work is the ablative therapy. Ablation means we burn the mucosa of the duodenum with some devices. So in this ablation, there is something which again you must have heard of, the duodenal mucosal resurfacing. This is again a simple OPD-based procedure where you all need a simple endoscope. The duodenal mucosa, what we do is we push in this at the aid of an endoscope, and then we push hot water through this balloon at 90 degrees centigrade, and we burn the mucosa of the balloon, of the duodenum, which chars the duodenal mucosa. It hardly takes 25 to 30 minutes. We will do it at the second part of the duodenum and slowly come up. So what happens when you do this burning of the mucosa is the circumferential ablation leads to thermal exchange, which, as I told you, we do with the hot water. And within 3 months, all this burned mucosa will come back to normal. Trust me, there is a randomized control trial published, and also there are quite a good number of studies published with this technique, and that too in the most impact factor journal in the gastroenterology called the Gut. And what has been shown in this is there is improvement in the glycemic index, improvement in the liver enzyme parameters, improvement in the HOMA-IR, then improvement in the lipids, and also the anti-inflammatory levels like inflammatory cytokines and also antioxidant capacity. So this is a very proven technique with enough amount of literature supporting that. But again, it's held up at the FDA for approval, but sooner we'll soon get it. But again, as you see, this is a little crude technique because you put hot water and then burn the thing. So now we have gone to the next level where we are going to do the same ablation of the duodenum with something called as electroporation. This is a generator which emits electroporation, which is a fine technique current of ablating this mucosa. In fact, surgeons are using this to ablate the tumors laparoscopically from much ahead of earlier times. And now endoscopically, we started doing this ablation of the duodenal mucosa, which is a more safer and refined method compared to the DMR, what I have shown. So as I told you, you do a generator and then you emit pulses and then ablate the mucosa. This is again not in the market, but there is a trial which has been done in Mayo Clinic, USA, and 2 European centers, and the good data of 60 patients following up for 1 year has come, and the second year data is available. Soon at AIG, we are going to get this in the next couple of months after the CDSCO approval. And the third one is a little fascinating, but I don't want to bore you. It's a little more technical endoscopically. See, you must have heard of surgeons doing a ileal interposition for this diabetes and obesity. So there is something called as the same thing what surgeons do. We do endoscopically, where we put in one scope into the mouth and one scope into the anus. And then both the scopes come and meet each other at the ileal, jejunal-ileal level. And then we release magnets which at the jejunum and ileum, and these magnets attach to each other, and then they create a fistulous opening where the food from jejunum directly falls into the ileum without getting absorbed, which is called as jejunal-ileal bypass. So this is again not available in the market, but there are people working on it. But I'm not very sure how far it will come into the market, because it's a little more robust and a little complicated. So the dual efficacy of this duodenojejunal bypass liners, you say, or the ablation is, it has got a glycemic control, it has got an indirect metabolic effect in terms of weight loss, and it has got a positive effect on the cardiometabolic parameters, as I told you before. Now, the next one, which you are all masters in this, the right side of my slide, the GLP-1 analogs and the GIP-1 analogs. So I don't want to talk on this pharmacotherapy, the newer drugs which are making a huge hue and cry in the NEJM papers every 3 months. It's coming like, a newspaper article. So you have the semaglutide, liraglutide, and the tirzepatide and the new molecules. So my feeling or my proposal is, I'm not saying we are going to replace the bariatric surgery, but in patients up to 40 BMI especially, if you tackle that patient who is diabetic and obesity with these two, as I told you, you do a ESG or you do a balloon where you will have around 15% weight loss, and you do apply one of these GLP-1 analogs, which will give you around 5 to 7% weight loss. So together, cumulatively, you can target around 20% weight loss. In fact, what I would say is how to choose a patient wisely is, if the patient has got a motivation for weight loss, if he or she is not a binge eater, and they want around 10 to 15% weight reduction as a bridge therapy, and after that they want to maintain, then this bariatric endoscopy alone is good enough. But if you have a patient, which is most common scenario, where they are obese, diabetic, and they want to lose weight, but they have no control on the food binge eaters. In those patients, if you do one of these endoscopic procedures and add on this GLP-1 analog, then the appetite will be suppressed by this, and then this also will give a dual effect, which will give you around more than 20% weight loss, which is at par with your surgical bariatric surgery procedures. So just to summarize, gastric endoscopic metabolic therapies and small bowel endoscopic metabolic therapies, as I told you, you have the balloons, you have the endoscopic sleeve gastroplasties, and in the small bowel mechanisms, you have the duodenojejunal bypass liners, then the ablative techniques, and these other fancy endoscopic techniques. So by and large, both of them will have the same thing, especially on the NAFLD, where they decrease the fat deposition, decrease the pro-inflammatory cytokines, reverse the fibrosis. If it is a gastric pathway, you have these, and if you have the small intestinal pathway, you have these things. And overall, main motto or the main mechanism is weight loss leading to improvement in the metabolic and other parameters like diabetes and obesity. So to conclude in the last couple of slides, because I want more discussion to happen, because I know it's really difficult to digest everything in one shot. But first, what I want to, I'm expecting is to have more interactive sessions on how to choose the patient, which is important. So endobariatrics is the future, where, as I told you, if you combine the interventions on the stomach and the small bowel with those GLP-1 analogs It's going to be the future in the next 10 to 20 years. And in fact, this bariatric endoscopy guidelines have been formulated. I have written with another colleague from Mayo Clinic in USA. And we last 3 months before, there was IFSO World Conference, that is International Federation of Surgeons for Obesity. So trust me, International Federation of Surgeons of Obesity has endorsed bariatric endoscopy as standard of care. And in the next 2 months, we are going to come up with a consensus published guidelines on bariatric endoscopy as standard of care. And as we all know, we as doctors and scientists, necessity is the mother of invention. And we are constantly struggling to get something very useful, minimally invasive for these patients with diabetes, obesity, and fatty liver. And as I told you, it's not a single man show. You need a multidisciplinary approach. You need a bariatric endoscopist, a good cooperative bariatric surgeon who refers patients to you. And more than that, the ecosystem should be filled with you physicians, diabetologists, and endocrinologists. See, I'll tell you, we have an endocrinology department of around five people. So if you ask me, let me tell openly, I hardly get 1 or 2 patients from that department to me. I mean, I'm not blaming anybody. Probably that's because the awareness is not there. Because it's not a competition between a bariatric surgeon or a bariatric endoscopist with a physician or a diabetologist or endocrinologist. It's a complementary, because you people will be doing the pharmacotherapy management. We will be acting as a bridge between you and the patient to reduce the weight so that your drugs will act well, and that enhances the quality of life or as well as the overall well-being of the patient. Then the other specialties like orthopedics and the anesthesia people, the pulmonologists, especially for OSA, all these have to be a team who will support each other, and then only these kind of programs will flourish. With this in mind, at the AIG hospitals, we have a department where it is dedicated for these patients with, in fact, the endocrinologists also sit in this department. The patients with the diabetes, obesity, and fatty liver, they're all seen in this department at one shot by this full team. And then, of course, the nutritionist I didn't mention. That's again the very, very key important person in the program. And we all see and then give an unbiased opinion of what is best for the particular person, whether you need only lifestyle or lifestyle with pharmacotherapy or lifestyle pharmacotherapy with endoscopic procedures or surgical procedures. So that's how it works, and that's how the success will become when you have a teamwork. So I would like to stop here and then take any questions, which will be probably more interactive and informative. Thank you for the opportunity.
Dr. N.K, you were silent.
Yep.
So, Dr. Ripun, you continue the flow.
Okay. Thank you.
So whether
very...
Dr. Snehal will tell you whether some questions are in the chat box or not. And Dr.
Yeah.
Vinay Dhandhania, he there,
Yeah.
he can, yeah.
Yeah.
So, yeah,
Vinayji,
Dr.
namaskar. Vinayji, namaskar.
Yeah.
Namaste, sir.
Thank
Namaste.
you.
How are you?
Absolutely excellent introspect into the subject, which is very new to all of us, in fact. So I do have a simple question. How do you define your patient to be put into EBT? I mean, keeping in mind, the definition of obesity is absolutely different from Caucasians. So how to select your patient depending on your BMI and other comorbidities? And we are nowadays hearing a lot of newer nomenclature, MFLD, then just a few months, 1 month back only, AH has introduced the term CKM syndrome. It's cardiometabolic kidney, cardiovascular kidney and metabolic syndrome. In the last month only.
Yeah.
So how do you tackle all this situation? Because basically, the aim is the same.
Exactly. So very good question, Dr. Ripun. So see, the thing is, we obviously will follow the BMI criteria of the Asians, which is the standard of care in, at least in our practice, in our scenario. That's number one. It's not only the BMI. See, what we need to emphasize to the patient is, as I told you, one, the BMI. Second, the comorbidities. Third, the fatty liver. See, I have seen many people in the daily practice who are obese with diabetes or standalone obese who come with a grade 1 fatty liver. And I have seen the transition. Within 5-10 years, they come back again with cirrhosis.
Yes.
So what we usually miss in daily practice is we don't look on the LFT levels, or sometimes we do look, and the radiologist is so subjective about the fatty liver. One will give grade 1, one will give grade 2, one will give grade 3, one will give 0. So that's one thing which we have to emphasize on. And I wouldn't say at this juncture that if the person is diabetic with obesity, that he or she is the only criteria. I feel more that if you have 3 of this in one basket, obesity, diabetes, and fatty liver. So if you subject them to one of these endoscopic therapies, I would say number 1, 2, 3 preference. BMI, the class 1 and class 2 obesity patients are the number 1 criteria. Second is the patient who is, that of course the obesity, what I told. Second is the fatty liver. Third is a diabetes. So, and the comorbidities especially. See, as I told you, the rule of 10, if the person is having obstructive sleep apnea or osteoarthritis or the fatty liver, these are the people whom we have to motivate more than a person who is alone, standalone diabetes or diabetes with obesity. That's what I mean to say.
Yeah, so I think Vinay, you see there are few questions in the chat box. What's your comment on this topic? And that Vinay, yeah.
Yeah, Dr. Rakesh, an excellent presentation and a very new concept, a new learning for all of us. Thank you very much for being here in this CME India meeting. So I have a very simple, just for the interactive interaction to go on. How is endoscopic bariatric surgery different than the conventional bariatric surgery as far as mechanism of weight loss is concerned? Because you were trying to club with GLP-1 analogs, but as we know in the conventional bariatric surgery, there is an increased surge of GLP-1, which is actually a most important mechanism of weight loss in these individuals. So is there any different mechanism of action as far as weight loss with endoscopic bariatric surgery is concerned? Because you are trying to add on extra GLP-1 receptor agonist. So that will be very, very helpful for all of us as well.
Yeah, very, very good question, Dr. Vinay. Very practical. So the concept of bariatric surgery, when it evolved, the concept of ghrelin is something which has come into the vogue.
Yes,
and, that's where the lap sleeve gastrectomies and Roux-en-Y bypass. Roux-en-Y bypass, again, as you told, that's on the duodenal level, but the gastric level is a ghrelin. But now the difference between that and the bariatric endoscopy is because we are not chopping off the stomach. In fact, we are retaining the fundus and then doing a accordion stomach, what we call, where we put a tubular stomach. The main mechanism what we propose is we are creating an artificial gastroparesis, where the food goes and lodges in the fundus and it won't trickle down fast as it happens, number 1. That is at the stomach level. The ghrelin concept has taken a backseat now. We are not, the recent literature, what has been worked on, that ghrelin is the one which is a main hormone in this appetite loss control and all. So that's now no more a theory as of now. The second is the duodenal bypass, what I have shown, or the RYGP, what surgeons do. So that is where the GLP-1 analog production will be more, which leads to decrease in the insulin resistance. That's what is a mechanism, which is alike surgery. There is no difference in the bypass versus the small bowel devices. But at the stomach level, this is what is I'm trying to tell you about. That's the difference.
So then by adding a GLP-1 receptor agonist, you are increasing the stasis of food in the stomach. Is it even the GLP-1 receptor agonists are known to cause gastroparesis like an environment?
Yes, exactly.
Satiety. So I don't think both of them together are going to cause a mess in the patients, or could be a cause of increase in vomiting or stuff like that.
That's a very good question. But as I told you, comparing to the sleeve gastrectomy, here the vomiting is very much, hardly have any vomiting. But the gastroparesis is something which will be add-on effect.
Yes.
which will decrease the appetite. See, I would suggest, or I would tell, there's no established evidence as of now, we are working on it. The GLP-1 analog combination with bariatric endoscopy is only in people who are binge eaters. You see, it's basically a psychological disorder, as we all know. If the patient is having a control on the eating habits, then you don't have to add the GLP-1 analog. But if they are binge eaters, then obviously that's one thing which will be add-on effect.
Yeah, Vinay, there are 4 questions
Yes.
in the chat box. Can you
Yeah.
see the chat box?
Yes, sir. Yes, sir. I can see that.
Yeah, you please tell.
So their first question by Dr. Snehal Bansode, your comments on weight recurrence following bariatric surgery and your experience on surgical revision for non-responders with respect to or development of upper GI symptoms in LSG patients.
Okay, that's a fantastic practical question. So, as I told you, all these procedures will have a weight regain. It's only a matter of time. Endoscopic probably will have a weight regain in 2 years. Sleeve gastrectomies will have after 5 years. So, if they have a weight regain, there are 2 things. In fact, we as endoscopists will do the endoscopic suturing of the residual stomach, which is again a daycare procedure, because doing again a redo surgery in a sleeve gastrectomy is something which is not really recommended, because already they will have some GE adient that will worsen. That is number 1. Number 2, add-on of GLP-1 analogs in these patients is something which is a boom for them now, especially in binge eaters. I think I answered the question.
Yeah, so Snehal, I think these all questions are by the delegates. So she just
Yes,
put it.
Oh.
Yeah. So Vinay, your next question there. You see the next question.
So recently we are having very interesting launch in GLP-1 basket. Like you talked about tirzepatide, which is a dual GLP-1 and GIP-1 analog. And recently is also a third molecule which is coming up is retatrutide, which is a triple action, which also acts additionally on glucagon.
Yeah.
And what the data are coming up is almost 15 to 20% even more than weight loss.
Yeah.
Don't you think it's going to be a medical bariatric surgery and we will not need any surgical intervention after these molecules come in?
Yes, of course, I completely agree. Only thing is we have to wait for the long-term side effects, which are unsung till now. But if there are no side effects, touch wood, I'll tell you, that's what I'm saying. So if you have even morbid obesity, that is, grade class 3, in those, if you do a combo of that with one of these simple endoscopic procedures, with due respect to surgeons, it's going to be a big challenge for them. I wish this will happen in the next 5 to 10 years. No, it's for the interest of patient, not for anything else,
Dr.
Yes,
Ripun.
I have a simple question. When you put a shuttle in the pylorus, is there any chance of developing some sort of pyloric obstruction symptoms in the patient?
Yes. Yeah, see, in fact, the balloons, what we put, sometimes they trickle into the pylorus, and then we have to, reshape them or readjust them. That happens. But again, pylorus is a very robust organ. It moves a lot. So the food will find a way into and then get into the duodenum.
Okay. And second thing is that in your own experience, how many cases, you do it primarily, I think the primary EBT, but how many secondary cases you have done till now?
Secondary in sense, post...
as a failure of bariatric surgery coming with a lot of complications.
Yeah. So
need to do one endoscopy.
Yeah. So as I told you, the sleeve gastrectomy, the pouch, the stomach is like a balloon. The more you put, it expands again. So the post-sleeve gastrectomy weight regain, they come back in 4 or 5 years. And when we just do 2 sutures and then make it small. So we have almost around 40 to 50 cases. But again, I'll tell you, Dr. Ripun, it's all the good rapport of you with your bariatric surgeon colleague. No surgeon will refer.
Definitely.
Snehal, and what are the questions? Can you read out?
Yes, sir. Yeah. Which intragastric balloons have received FDA approval? Any personal preference for specific intragastric balloons?
Okay. So there are 2 gastric balloons FDA approved. One is the Orbera from Apollo, and there's another one called SPARS balloon. As I told you, Orbera is a non-adjustable balloon, Sparge is adjustable balloon. Both are good, and these are two FDA approved, and both are available in India.
Yeah, next.
Thank you, sir. So the next question is, which patient profiles are best suited for the use of liraglutide?
Which patient profile? I think instead of me commenting, there are the giants on the screen.
Vinay will cancel. Yeah, or Ripun cancel. Yeah.
One
Yeah.
thing, I have a very interesting component of your talk that you've been talking about NASH and NAFLD and prevention of hepatic cancer. And we don't have much data as far as approval of bariatric surgery for NAFLD and NASH and prevention of progression to cirrhosis. There are some data which are like the other way around. There's an increase in NASH or NAFLD after a bariatric surgery. Don't you think they are pretty contradictory? Because there is no recommendation today to treat a NAFLD or a NASH. You'd go ahead with a bariatric surgery.
And, Dr. Vinay, there is literature. In fact, I'll tell you right now at this. So there is one Lancet publication where they have put a balloon, pre and post balloon, endoscopic ultrasound guided liver biopsy was done, which showed significant improvement in the reversal of fibrosis. That is number one. Number two, on this endoscopic sleeve gastroplasty, there's another publication in Lancet in 2022. It's a merit trial where they have found the similar findings. We have our own data, which we have just sent it to DDW, where we have done this adjustable balloon and I have done pre and post paired biopsy, where it is shown. And we have surgical data also on that. We have, in fact, liver biopsy proven, not even non-invasive markers.
Okay,
as I told you, progression to HCC, of course, we don't have a data, but this alarming rise in fatty liver people going to HCC nowadays. That's what I mean to, because there's two things in that. One is Hep C is controlled, Hep B is a little on the declining trend. So this fatty liver is the burning topic, which is going into HCC.
Rakesh, I think
we need to have some robust study on the effect of EBT on NFLD and
yes,
liver diseases.
There are many in the pipeline. In the next 1-2 years, we'll be getting even the RCTs also on that.
We have shown the data also that all the liver transaminases are coming down after EBT.
Yes, of course. In fact, there is a reversal of fibrosis, not even the AST.
I've seen you that.
Yeah, Rakesh, I think there are two interesting questions. One is, does bariatric surgery induce short-term type 2 diabetes remission? So can we also go for these techniques for the diabetes remission? What's your comment?
Yeah, definitely yes. I don't say it will be completely non-diabetic kind of, but again, the insulin requirement, if they're insulin dependent, will come down, or even the OH requirement will come down.
Yeah, patients now are very conscious about the looks. What is your take on post-operative hair loss? One question is here in the chat box.
Oh, I don't have any comment on that.
And which patients are not suitable for surgery? I think this is one question more.
Yeah, surgery in sense, again, because high-risk anesthesia patients and they have any cardiac problems, they are not fit for surgery. But in fact, we do the balloons in a conscious sedation and even the endoscopic sleeve gastroplasty in some patients who are not fit for GA under conscious sedation.
So I think recurrence, suppose you have done a technique and then there is recurrence of the weight gain is happening. So what do you do then that?
Yeah, so it all depends on the eating habits. I agree with that. There is a regain of weight again. So if it is endoscopic procedure, you can again reproduce. It's something called as redo ESG, which we do. You can reproduce it, or you have to go for other methods of surgery or the pharmacotherapy.
So I think we have only 3 minutes left. So Dr. Ripun, your final comments on this topic, and do you see one day this technique will replace the physicians and diabetologists for the remission of the diabetes and obesity? And
I don't think so. I don't think so, because initially also when I said that treatment of obesity is totally different, but preventing obesity is quite a cumbersome procedure. so long you cannot have a control on your behavioral therapy, you need to improve right from the childhood your cognitive power and your inclination towards the hedonic behavior or hedonic eating. Until and until we can do this, teaching starts from the from the womb itself. Because if we change our atmosphere inside our home, in the peer pressure, teaching habit, teaching in the school, everything will change. What we need to understand that we have to educate our girls regarding the nutrition, which is the better nutrition for you, because the girls are the future mothers. If you can this sort of behavioral treatment to our girls and behavioral therapy, they can adopt any good habit for their children also in future. So, obesity, this is the thing that we are losing our cognitive power, going to the reward system. And all this interaction between the cortical limbic system, brainstem, and the prefrontal cortex is almost lost. That education should be given right from the childhood.
It's a psychological disorder, yes.
And I just want to add to Dr. Ripun's expert comment that what Dr. Rakesh wants to say, a teamwork has to be created, which is very, very important. We need to start referring the eligible patients who will be benefited at a very early stage. I see patients at the age of 30 with polycystic ovarian disease, a body mass index of 40. They struggle for their survival at the age of 30. They are depressed. And if you refer to them for a bariatric surgery, they will undergo a bariatric surgery, they will lose weight, they will get married, and they will have children as well. So this is what we need to actually intervene rightly. And a team approach is what is needed. And education and behavioral therapy definitely holds a very strong position as far as treatment of obesity and chronic disease is concerned. So
Excellent.
Very well said. Very well said.
Yeah, so final comments, Dr. Rakesh.
Yeah, I would say, as you all people have re-emphasized, it's a team effort, and it's all should work on the same page. And as I told you, if you have that rule of 10, which we can advocate in all our patients with diabetes, that itself is good enough. You don't have to tell them to go for 50-20% weight loss and all. The rule of 10, if you can just inculcate, then they'll have a fantastic overall transformation.
Excellent one. So I think concluding this excellent presentation by Dr. Rakesh, and I think a great thanks to you and our very reputed chairpersons, Dr. Ripun and Dr. Vinay. So what we think that we are approaching 2024, and we have early evidence. I will say that we have got early evidence that is showing that the endobariatric techniques that are minimally invasive, non-surgical procedures are emerging at a very fast pace. 2 years back, I had also interaction with Dr. Rakesh, but lots of things new has come up. So they bring not only significant and durable weight loss, but also a long-term improvement in the obesity-related metabolic comorbidities. So both the gastric and small bowel EBTs promote effective weight loss. It can help ameliorate hepatic steatosis, early liver fibrosis, which you have given a very great message to us, insulin resistance, and cardiovascular disease risk. So further advancement on endobariatric techniques might bring new hope, and conventional bariatric surgery may be a talk of past. I see the future that the bariatric surgeons might be lost someday in the future. With this hope, thanks very much. Final comment, Dr. Ripun. Do you see any such hope?
No, I don't think so. Okay. So long the civilization remains, the obesity will remain.
Yeah.
So everyone has got his own sons. You can never change that.
Yeah,
but Rakesh, you have given us a very good opportunity in future also to talk to you, and possibly I do have the few children also, the children obesity. Is having 28 BMI.
Yeah, so I'll comment on that. So in our guidelines, now it's been endorsed by the Bariatric Surgical Society of the World that bariatric endoscopy is standard of care for adolescents also. In Saudi, there is a group who has published on this EAG on 1,000 adolescent patients. So it's a standard of care. Surgery is not a standard of care. This is a standard of care.
Yeah.
Even for those group of patients, even liraglutide has been recommended by AD also, with non-diabetic obesity in adolescents. Thank you so much.
Yeah, Snehal, your last
Yes,
comments.
sir.
Yeah, wind up.
Yes, sir. Yeah. Thank you so much, Dr. Rakesh, sir. It was an excellent session by you and a fantastic moderation by Singh, sir, and not to miss out on the clinical expertise and the pearls shared by Dr. Ripun, sir, and Dr. Vinay, sir. We are happy to share with you that, sir, we had more than 1,300 live audiences,
Good.
and the audiences have very much appreciated the session and have passed on their regards to all the stalwarts we have here from the industry. So many congratulations to Dr. Rakesh sir, Dr. Ripun sir, Dr. Vinay sir, and Dr. Singh sir for helping us to put together this successful event. And we really look forward to having you on board for many more such interesting sessions in the near future. Thank you once again from the entire USV family. Thank you, sir.
Thank you. Good night. Good
Thank
night.
you. Good night. Good night.
Good night. Good night.
Good night, Dr. Rakesh.
Thank you.
Good night.